Angeles County right now, building upon kind of the broader components of the drug Medi-Cal organized delivery system. And so to give you a sense, we really started this practice this effort in February 11 of 2016, almost a year now, where we drafted our implementation plan to really give an outline of what Los Angeles County is going to be doing. It's kind of what we describe as a skeleton plan, really give that broad overview of how we're going to take the components in the drug Medi-Cal organized delivery system and apply them in Los Angeles County. That was when it was submitted. So subsequent to that, we needed to have a broader stakeholder process, which we launched in March of 2016, and that built upon work that we had done earlier in the year to design the implementation plan. And really wanted to get feedback from our stakeholders, both our current substance use disorder providers, as well as other county departments and stakeholders, to help us build a system of care that is modern. That we take the levels of care that we'll talk about in a little bit and really take a look at what are the effective components of that and design the benefit package. John mentioned that on July 1st, we launched the My Health LA SUD benefit in advance of us participating in the waiver. And then on July 27th, we received approval on the implementation plan from the federal and state government that we had submitted earlier in the year in February. And then more recently submitted our fiscal plan in August, which detailed the kind of advances in rates that we're hoping to achieve so we can build this system of care. We are currently in negotiations with the state on those rates, and hopefully we'll hear shortly and we'll be able to share that as well. As we move forward, we hope to have the new contract signed between the county and the state around March of 2017, and then to launch the new benefit package come July of 2017. So to just give you a sense of the scope of change that we're going to be looking at, you can see from this graphic kind of a breakdown of the total Los Angeles County population by youth and adults, and then of those who are eligible for Medi-Cal and those that we estimate based on prevalence of SUD needs in communities who we think might be eligible for drug Medi-Cal and may enter our system of care. We know that there are many more people who need substance use disorder services than actually access them, so a lot of our work is going to be on outreach engagement. But about 7.4% of the population of youth we expect to be DMC eligible, and about 13% for adults. And over the next 3 years, we expect to see a substantial increase in the number of people served in our system of care. So 55% increase for youth and a 47% increase for adults. Now what that helps us see is the growth in the population, but also this has been an opportunity, I think, as we've talked about a little bit, that previously we've been restricted by categorical funding. So, our block grants, CalWORKs funding, general relief funding, that really put a kind of capped allocation on services and the people who can be served. As we transition to drug Medi-Cal, which is an entitlement benefit, we know that we're going to see our system of care growing. So we've got a gap in services based on what we currently have in our system of care and what we think we're going to need eventually to meet the needs. So just to see here in the adult system of care, we expect to see a need for a 216% increase in outpatient slots. Our withdrawal management program is much less expansive, so we expect to see a 316% increase. So this really demonstrates opportunities for programs to grow and for service expansion to happen. The graph that you have there of Los Angeles County is really just a depiction of where we think that most of the eligible beneficiaries reside. As you can see, a lot of that is in the south part of the county and the north part of the county through the red, and the blue is areas of less concentration. These are areas where we expect to see more program growth as we move forward. So here to kind of depict our system of care, as I referenced just a moment ago, the fruit pie graphic really kind of depicts our overall kind of patchwork of funding that we have in our system of care right now. We pull together resources from the federal government, from the local government, state realignment funds to help build a sufficient network of services for our patients. We know that as we transition, though, come July 1st of 2017, drug Medi-Cal, the graphic there, is really depicting, how we expect that drug Medi-Cal is going to become the primary payer for most patients and most services in Los Angeles County. It's a very big shift in how we'll be funding our system of care moving forward. So this becomes important for our provider network. Right now, relatively modest amount of our providers are drug Medi-Cal certified. It's our single watermelon graphic right there. And we move towards, again, July 1st, 2017, all of our contractors are going to need to be moving to be drug Medi-Cal certified for all contracted sites and all levels of care. So a very big shift in how we'll be delivering services. And probably the biggest component for those of you who are familiar with the drug Medi-Cal system, this is specific to the DMC system and not our services overall, but it is a very narrow scope of benefits. It really focuses on outpatient and intensive outpatient services and a heavy reliance on group counseling as the primary intervention in those services. Less so on individual counseling. And residential is presently limited to perinatal patients and then also opioid or narcotic treatment programs. As we move forward, the drug Medi-Cal benefit becomes much more expansive and really helps us build a very strong continuum of care through that funding source. The new components for this, of course, are residential services. There's going to be 3 levels of care. The first is going to be a lower intensity, about 5 or less hours per week. The second is going to be quite a few more hours, but it's focusing on the substance use disorder population as well as individuals with more enhanced needs. Many of those would be the co-occurring disorder services. Another component is withdrawal management is now going to be funded under drug Medi-Cal, both what we're familiar as detox programs and more of your residential component, as well as something that's largely new for our system of care, which is ambulatory or non-residential withdrawal management services. And then probably one of the biggest components to building the system of care is the ability to provide individual counseling sessions under the drug Medi-Cal benefit. This is very significant for this benefit. Previously, it was limited, really to kind of intake activities and crisis activities, but now it's going to be based on individual patient need and medical necessity. So it really gives new opportunities to have one-on-one interaction with patients, as well as to have family therapy sessions as well. So big improvement there. And then as we talked about briefly, is the new case management care coordination benefits under drug Medi-Cal and new recovery support services benefits. And I'll talk about that a little bit in more detail in a few minutes. So other big components and what this really means for us as we build this modern system of care and respond to the expectations of the waiver is to really look at how can technology-based solutions really improve care. So right now, for those who are familiar, we have a data collection system called the Los Angeles County Participant Reporting System, where we gather basic demographic data, patient data on our clients. And then we do not have a electronic health record system across our system, although several of our providers do have agency-specific ones. And then we have a web-based auditing tool and web-based claim systems. As we move forward, the county is looking into developing a managed care information system that would really serve as an opportunity to do entry of case notes, treatment planning, things like that. It's a system that would be available to our SUD contracted providers if they want to use that in lieu of an agency purchased electronic health record. So that should really help, particularly the smaller and medium-sized agencies, move into the ability to input their patient information electronically. John referenced a little bit the rather significant changes in the quality improvement and utilization management components. We have contract monitoring right now, but this really kind of brings it more into looking at the quality of services that are going to be provided. Are the evidence-based practices being implemented well? Are patients receiving services at the right level of care and transitioning through care in appropriate ways? And are we documenting services in the way that we should to demonstrate medical necessity? Some of the things that we had heard throughout the sessions yesterday. We also, as was mentioned, residential services is probably one of the more challenging additions. It's very exciting that residential will be a reimbursable benefit under drug Medi-Cal, but it's also a capped benefit for us. And So for adults, that means that there would be 2 non-continuous 90-day episodes with 1 optional 30-day extension based on medical necessity. For adolescents, that's 30 days. And one of the major challenges here is that one thing that we're looking at internally, and how do we manage this, but at least under the drug Medi-Cal benefit, if a patient, those 2 episodes are not a max of 90 days, it's not cumulative. So if you have a patient that comes in, stays for 10 days, that's 1 stay. So it is a very limited benefit. So we're looking internally with our resources to see how we better manage that, but that's one of the more challenged components of the waiver. And we also need to provide prior authorization for that, which is different than we do currently. And that's going to be handled by our medical director's office and would impact all of our residential treatment slots. And then I'll talk in a moment about the bed registry, but really we need to look at what kind of slots do we have available within our system. So there's an electronic system that we're going to be developing around that. So as far as kind of that LA County graphic alluded to earlier, is that, it's a good opportunity for our providers and our provider networks to really start taking a look at how do we expand services for the populations that we serve? How do we make it more accessible? How do we make it meet their needs better? So the funding is the first main component, is that the entitlement component of drug Medi-Cal really helps us expand service access throughout the county, and the fact that it's not capped. And so what providers could do is to look at, where can we add locations that might be underserved to better engage patients where they work and where they reside. Also looking at how do we enhance days and hours of service to help meet the needs of our patients. It may not be reasonable, especially if individuals are re-engaging in work or engaged in work, to provide services Monday through Friday, 9 to 5. But are there times where we can provide more expanded evening hours or weekend hours, not only to be more patient-centered, but also looking, can we do admissions on the weekends and on the evenings as well to kind of better target the population that we serve. Another essential component is looking at how do we create programs that target and better serve specific cultural populations that meet the linguistic needs of our patients. And this will create more opportunities for us to do that. And then also for agencies to look at, beyond the continuum of care that they currently provide. So if agencies currently provide only outpatient services, how do we expand that to intensive outpatient or to add ambulatory withdrawal management? So these are real good opportunities for agencies to look at how their business model is structured, how their agency is structured to build a more comprehensive continuum of care within their current network. This again is something that had been significantly restricted before based on funding sources, but we will be working with agencies to kind of look at how services can expand moving forward. And then what we're going to spend most of our time today talking about is a really exciting component of this new system of care. We know that we've done good work through our provider networks on helping patients get in touch with mental health needs, physical needs, social services needs, and things like that. But this is really a greater opportunity to really see integration of care materialize within the STD field. Wes talked earlier about kind of our three-legged stool, and this is really a component of our ability to help build and become a more integrated partner with the mental health and health services systems. So I think I'll spend most of the time talking about this in other slides, but if you downloaded this, this kind of gives you a comparison of where our system of care is at now and where we're going. So to kind of transition a bit, I wanted to talk a little bit about how patients will be entering our system of care as we move forward. There will be some changes and some things that will remain the same.